Hello everyone. This is a new lecture series about maternal medicine, one of the most complex topics in obstetrics. And this should be the first lecture, which is about epilepsy with pregnancy. So basically, this series of lectures is just clinical. It doesn't have a lot of academic background. So it's basically for your own practice and for if you're interested in preparing for something like MCOG, it's also good for it. So try to be focused, clear, and hopefully we can make it as a short lecture. So let's get started. So first thing, with any medical disorders, with any problems with pregnancy, I would like to just split it into 4 stages. So the first stage is basically, ideally should be before conception, before she gets pregnant, when you can make everything optimized before she goes into pregnancy and do your workup and everything. But in many situations, this is not an option. And then you have to see it when she gets pregnant, like in her booking appointment or like the first antenatal visit, when you have to adjust everything. Not ideal, but this happens a lot of times. The second stage is basically antepartum management, which means management throughout pregnancy. And this ideally should be done by both the obstetrician and a neurologist. The third stage is management during labor itself, when labor gets established or when you start induction of labor. And the fourth stage, of course, is after she delivers her baby. So let's start with the first stage. So basically, I would like to go with a checklist. And I really recommend that you have your own checklist, like even a printed checklist or something on your computer. So every time you see a patient with this particular disorder, then you know what you need to do. Just check, check, check. At least till you get really familiar with it, that you don't have to recall anything. So I would say, in the preconception appointment, if a lady is planning to get pregnant and she was seen by a neurologist and he recommended or she recommended that she sees you before she plans to get pregnant. Or if she's coming, unfortunately, with a positive pregnancy test and like, okay, that's it, we have to keep going. So I would say your first point in the checklist here is actually diagnosis verification, which is in many situations just get missed. Here I mean that you shouldn't be saying I'm treating epilepsy with pregnancy. Epilepsy is a diagnosis, and you can say it just because a patient just mentioned that she used to have seizures or something like that. So seizures themselves do not mean that the patient is having epilepsy. And there's like, as you see on this slide, there is a lot of differential diagnoses. I'm not going to go through this, but just telling you some of them are really acute or just occasional, like hyponatremia, hypoglycemia, and some of them are like more of a subacute situation, more serious, like space-occupying lesions, brain tumors. So you shouldn't be just guided by the fact that she knows that she's having seizures, but she never seen a urologist or never had a formal diagnosis, or a formal diagnosis was made in suboptimal circumstances. So I would say, first thing, you should verify the diagnosis, meaning that it's really made by a neurologist with a plan of care. The other thing is you need to really know if we can still consider that an epilepsy, which means if a woman didn't have any epileptic seizures for 10 years at least, 5 years of them, like the last 5 years, are actually while she was not taking any medications. This means that I will not count that as an epilepsy, or like, let's call it a resolved epilepsy, but you will not treat her, you'll not manage her as an epileptic patient. So this is important always to ask, even if she has a history of epilepsy, when was the last seizure and when was the last time she took a medication? Similarly, if the patient just mentions that she had seizures when she was a child, which is a common situation, but this resolved later on and she never had epileptic seizures, same thing, that doesn't count as an epilepsy and you don't have to treat it as epilepsy with pregnancy. That's important. The last thing we always like to say, remember, CT and MRI are safe in pregnancy, especially that you're basically doing it on the brain. So if there is any need for further investigations for a patient that has not had established diagnosis of epilepsy, it's okay to do a CT or MRI to just verify the diagnosis if needed. But typically, you don't do these decisions yourself. There should be a neurologist who's guiding these decisions. What you say is just, okay, it's safe. So this is the first step. You need to verify the diagnosis. If the diagnosis is verified, I would like to do a risk stratification, which means, okay, we know this lady has epilepsy, but again, we need to know when was the last epileptic episode. We need to know how is her situation with medications, because we know that 2/3 of women typically do not get any epileptic seizures during pregnancy. They just do fine, 2/3 of them. And actually, to be more specific, if they are known to have generalized epilepsy, the chance is 74% that will go fine during pregnancy. The percentage goes a little bit lower if she's having focal epilepsy, it's 60%. It's just some, I would say, general numbers that you can use always to talk to your patient and just reassure her of the situation. But it's important to say always that the most important situation here, or most important question, is when was the last seizure? When the patient had the last seizure and how she's doing with her medications. Because typically, a seizure-free interval before pregnancy, or like the time that elapsed between the last seizure and pregnancy, is probably the most important factor to predict her risk of having seizures in pregnancy. And this is why I always say, just with the first visit, just classify or stratify your patient to either a low-risk patient. Actually, if the patient didn't have any seizures for a good amount of time, she can be classified as a low risk and be managed during pregnancy as a low risk. However, if the patient has been really having seizures recently, I would say the highest risk if she's having seizures within the last 1 year before she gets pregnant, then she's in a highest risk. And those are the patients that should be really treated as a high risk. So it's important to ask these questions. And as you see in this slide, we always say, be careful. 15% of patients who are taking the medications for epilepsy basically stop their medications once they get a positive pregnancy test. Basically because they likely know that these medications are not safe in pregnancy, or they were told not to get pregnant while they are using these medications, or to come and counsel if they want to get pregnant. This is very important, and this is not safe. Always advise your patients, even on phone call, like one patient calling you, I'm pregnant, I'm scared, don't stop your medications, because that's not safe. There's a risk, of course, but it is what it is. You're already on medications, you took the medication, whatever happened, and it's still, as we will see later, it's not like a huge risk. But definitely, if you stop taking the medication, there is a very likelihood that you're gonna be in seizures pretty soon. So this is a second on your list. Just stratify the risk, know if she's a low risk or a high risk for having seizures in pregnancy, and then you can plan her future care in pregnancy. The third thing here is actually reviewing the medications. And I always like to say that you are not the person who's supposed to change the medications, change the dose of the medications. That's not your rule at all here. But you are actually working with a neurologist to find the safest regimen for this patient. So you definitely, if you're the one who's seeing the patient, you need to refer her urgently to a neurologist and give clear recommendations about what you think could be safe on pregnancy. And in pregnancy, let's say, always, I mean, if possible, because your priority here is to control seizures, but your priority here is actually to give her the lowest possible dose to control seizures with actually one medication. We're trying to avoid a polytherapy, or like multiple medications, as much as we can, unless it's really inevitable. So this is your priority. So you tell the neurologist you need the smallest dose, you need it to be a single therapy if possible. And the third recommendation is you can tell the neurologist what medications you think are okay with pregnancy or is the safest in pregnancy. So I will tell you number one, basically, on this list is lamotrigine. Lamotrigine is actually, there is no evidence that we have right now that says it really increases the risk of congenital anomalies at all, which is good. again, these studies actually are still deficient. We don't have all the data that we need to verify this 100%, but to the best of our knowledge, it doesn't increase the risk of congenital anomalies, which is great. So lamotrigine is probably the best option with the lowest risk. The second on the list is actually carbamazepine. And carbamazepine is known to probably increase the risk of congenital anomalies, but it's still, the increase in the risk is not major compared to other medications. And actually carbamazepine has been related to two anomalies. So cleft palate is one of them. And as you see, you typically prefer to go with the risk of cleft lip and palate rather than going for the risk of cardiac anomalies or neurological anomalies. So even with the anomalies associated with this medication, there are still things that can be managed and corrected easily. There is also some evidence that it increases the risk of neural tube defects, but to be honest, the data says 3%. And this is really a slight increase, if any, above the baseline. So again, I mean, this is probably a good profile for a medication to be used in pregnancy if needed. Definitely, the worst is valproate. So that's a straightforward answer. Don't use a valproate. This is the most famous medication not to be used in pregnancy. And the reason is it really increases the risk of congenital anomalies, and actually even the significant ones. So cardiac anomalies, neurological anomalies, and hypospadias. And obviously, it's not about only the type of anomalies, but the percentage. Valproate actually was found in some studies to be associated with like 9% risk of major anomalies. So that's definitely like 3 times or more higher than the baseline. That's significant. So valproate is not an option. And of course, as we mentioned, polytherapy is not an option as well. So we should avoid that. There are 2 medications, just remember, starting with the term phen. So phenytoin, phenobarbital, these 2 medications are in the middle. So I mean, if you can't control things with lamotrigine and carbamazepine, then you may use the phenobarbital, the phen. Just remember that we have that weapon as a second line, the phen, the phenobarbital, and the phenytoin. So the phenytoin is associated with cardiac and palate anomalies, or cleft palate basically, and phenobarbital is associated with cardiac anomalies to start with. So there's something in the middle if you can't control with the safer drugs. It's important to know that with these medications, there are 2 common risks that we always mention. The risk of fetal growth restriction, which increases like 3.5 times the baseline, and the risk of neonatal ICU admission. So what we make of this information is we know that those babies, if she's on medication, she is at, or the baby's at higher risk of fetal growth restriction, which means that the baby needs serial growth scan to be planned later in pregnancy. And for neonatal admission or need for ICU admission, it's basically that you always need to be on hospital for delivery, and the pediatric team should be aware of this patient and should be available if needed to assess this baby. So that's 2 things that you make out of this information. So the last thing in your checklist for the first stage is basically counseling. And counseling here means basically that you talk to the patient. She typically should ask you like what it means when she gets pregnant while she's known to have epilepsy. So I would say you should discuss fetal risks and maternal risks. So fetal risk, basically, there's the risk of miscarriage and the risk of congenital anomalies. This is straightforward. Risk of miscarriage, risk of congenital anomalies. And we talked a little bit about congenital anomalies because we think the increased risk of congenital anomalies is almost exclusively related to the medications. It's not just because of the epilepsy. So if the patient is not on medications, the risk of having congenital anomalies with epilepsy is 2.8%, which is comparable to the baseline. So it means that the problem is in the medications. If the patient is known to have history of congenital anomalies in a previous pregnancy, actually the risk goes up to 17%, pretty high. But I would say here, if she's on medication, then you should tell her that it's related to the dose, related to the number of medications, related to the type of the medication. So it's not all the same. It's not like just the fact that you're taking medication means that your baby will have congenital anomalies. And as I mentioned, she shouldn't be stopping the medication. Even with the worst case scenarios, valproate, the risk in some studies says 9%. And I'm saying that also because some doctors really rush on an advice for miscarriage, for a medical miscarriage, just saying, you have been on valproate and all of a sudden you discovered you're pregnant. Now you're 8 weeks pregnant. Then we have to do a miscarriage. And that's not true, to be honest. That's not true. You should give the patient some numbers. And if the risk is 9%, 8%, then it's not reasonable to say, I will just go out right away and just proceed with a miscarriage. It's still a good chance that the baby will be fine. So that's important to say. Maternal risk factors, and most of them you really don't do much for. It's just to be aware, just to prepare your patient without getting her really anxious, that she's at increased risk of antepartum hemorrhage. Basically, two things: the risk of bleeding during pregnancy or after delivery, which is antepartum hemorrhage and postpartum hemorrhage, and the risk of hypertension, the risk of preterm labor, the risk of having to have an induction of labor or a C-section for some reason. And again, I mean, you don't really do much for this. It's just to be aware that she's a high-risk pregnancy to start with. And again, I mean, if she's really well controlled, no seizures, it's unlikely that something of these problems will happen. So let's go to the second stage, which is actually, okay, the patient is established, you're seeing this patient, now we have to plan for an antenatal or antepartum care during her pregnancy. So what's your checklist? First thing, medications, straightforward. What do you need to do, or what medications should be on is definitely epileptic medications. But as we said, she should be following up with a neurologist. You don't typically really do blood tests to monitor the level. That's not something that we do, and we don't have to. So you just need to keep her on the medications, be sure that she's under control, and there is a free communication with the neurologist about that. The other thing is definitely folic acid. So those patients, as we mentioned, at increased risk of neural tube defects, and for this reason, she should be at the higher dose of folic acid. That's important. So it's not just the 0.4 or something, it's just 5 milligrams of folic acid daily. And she should do that actually before conception. So that's why I said preconception appointment is ideal. So she should start that preconception and then continue doing that, 3 months before conception till the end of the first trimester. So almost 6 months of folic acid, high dose of folic acid. The other thing is, this is the medications, basically, straightforward. Maternal safety is your second checklist. So you should be sure, especially for those at high risk of seizures, that she has a safe environment. That's your job. You should really explain that to the patient. You should be sure that she really have support at home if she gets into seizures, because seizures can really cause a lot of problems in pregnancy and can really get the baby hypoxic, get her into traumas. Obviously, some of these can really result in like placental abruption. There's a lot of things that can happen, and she will need an immediate assistant and hopefully someone who's witnessing what happened to actually help us to do a correct assessment at the time she presents to the hospital. So she needs immediate assistance, and she needs to have a good support at home for this. And the other thing for maternal safety is you always should screen, even like with simple questions about her mood, her cognition. Just be sure that she's doing okay, because there is a lot going on with epilepsy, especially if she's a high risk and there are things going on. You want to just reassure her, just be sure that she's doing well with the mood and she doesn't need any extra assistance from the prenatal mental health point of view. So that's another thing about safety. So that's your second thing. The third thing is just be sure that the baby is safe. So medications, maternal safety, and fetal safety. And we say fetal safety, it's really straightforward. So anatomy scan, nothing new. We all do anatomy scan for everyone. But I mean, for this patient is of particular importance, especially if she is on medications, just to be sure that we check on any anomalies and we have a low threshold of referring if we're having any concern about the anatomy scan. And the second thing, as I mentioned earlier, is to do a serial growth scan starting at 28 weeks, every 4 weeks, check on how the baby is growing, especially if she's on medications. The third thing, and I always say that, no need for CTGs. Basically, CTGs are sometimes overused in many situations. You really don't need it, because just think about it. I mean, what the CTG will tell you in a patient with epilepsy. CTG, I mean, just thinking about epilepsy, it doesn't cause any like chronic hypoxia to the baby that it can cause any problems. And you're already following on that by doing a serial growth scan. Acute events are acute events. So if the patient goes into seizures, then that's a different story. But I mean, you don't have to do it as a routine, because you will unlikely to see anything that's suspicious, because there's nothing going on. Typically with seizures or with epilepsy, it's either an acute event that you need to check on, or a chronic problem related to, for example, to the medications, and then you need to be sure that the baby is growing fine. So that's basically it. All right, so third stage, intrapartum care. So let's think about that. First thing before we start the management during labor is there are always questions for any pregnant lady that you need to ask yourself. When I'm going to deliver, how I'm going to deliver, where I'm going to deliver, and then we can go from there. So time of delivery, really nothing. Like any pregnant lady, you make the decision based on obstetric factors. If she's doing okay, baby's doing okay, you don't have to deliver any earlier, just leave it as it is. So basically there is no need for an active management. In really few situations, some women really get poorly controlled in pregnancy for some reason. I mean, they have been doing fine, and all of a sudden when they get pregnant, especially later in pregnancy, they get a lot of epileptic fits or epileptic seizures, and you're worried, so neurologist is worried, and then you may think, okay, maybe that's pregnancy for some reason, it's making her get those bad seizures, and then you think about delivering early. But straightforward answer, you typically don't have to change the time of delivery or plan for a different time of delivery just because of epilepsy. Same for the mode of delivery. You don't have to deliver her like vaginally or by C-section for any reasons related to epilepsy. It's fine. Just do what is indicated for a pregnant lady. Again, the only exception is some women really have very bad seizures, recurrent seizures toward the end of pregnancy, and then you feel like that's not good, and you think if she's doing that in pregnancy, and we all know that if and like women with epilepsy typically at higher risk of having seizures when they go into labor compared to during pregnancy when it's not stressful. And if she's having seizures, bad seizures, recurrent seizures in pregnancy, it's gonna be really a hard situation in labor. So in these circumstances, you can talk about it, discuss this, and there's a good chance that you will have to do an elective C-section just to avoid the situation of going into seizures at the time of labor. But otherwise, straightforward answer, time and mode of delivery shouldn't be really affected by epilepsy except in very few occasions. Where to deliver? Hospital, of course, because she can get seizures. You don't want that to happen at home. As in high risk, obstetric-led care, sure, because again, she can get into seizures, and we know that the baby may be small in size, things like that. And we always say, obviously, one-to-one care. So it's just like for every patient, there should be a midwife or a nurse, depends on the setting you're working in, that is actually in the room with the patient to take care of her. Of course, I would say continuous fetal monitoring. I mean, you would argue if the patient is really well controlled, never had seizures or anything, and things look straightforward, I wouldn't say you have to do a continuous fetal monitoring. To be honest, you don't have to. There is no reason. You're not expecting anything bad. But if the patient actually is at high risk of intrapartum seizures, which means that she has been not super controlled in pregnancy, she had some occasions of seizures in pregnancy, then I would say yes, keep her on the monitor, because it can happen. And it can happen in labor that she gets into seizures, and then it will be really challenging to put her in the monitor. And as you know, at the time of seizures, the baby can really get hypoxic, and placental abruptions can even happen, and then the baby will really not recover from this occasion. If she is not connected in the monitor and the baby starts to have seizures, then you have to connect her to on the monitor. And actually, in this situation, you will keep her in the monitor, because this can happen again. But if she's really a low risk, straightforward, hasn't been having really bad seizures, I would say it should be okay that she's not doing continuous monitoring. So that was the first thing. We just made the circumstances, but the biggest two things in your checklist in intrapartum care is obviously preventing seizures and managing seizures if they happen. Two things, straightforward. So how can I prevent seizures? You should be aware that the risk of seizures is 3.5% in those patients. So definitely it's higher than antepartum. So if she's in pregnancy, the situation is, typically it doesn't really cause her to go into seizures, but in labor, there's a lot of risk factors that can cause her to go into seizures. And that is why there should be a good team communication about how to take care of this patient. And you should really know your team, if they are really comfortable managing those patients, or if they need some, just some advice, recommendations, explanations of how to take care of those patients. So I would be more specific. These are the 4 things you can do to actually reduce the risk of seizures in labor. First thing, never stop the medication as usual. So if she was on medication during pregnancy, just keep taking the medication regularly at the time of labor. Just one thing. The other thing, pain control. So definitely pain can cause her to go into seizures. So be sure that you're proactive with pain management, get her comfy. If she's planning for an epidural, try to make that as early as possible. Really get her pain under control. And I would add to that, just be sure that she's well hydrated, and the circumstances is as quiet as possible for her. So should be really those 2 factors, like good hydration is one of them, and pain control is one of them. There should be also oxygen available in the room for sure for these reasons. The other thing is there are certain medications that she should never be taken in labor. One of them is pethidine, and pethidine is actually one of the opioids that are really short acting, act for a short period of time. So they are really popular in some hospitals, not all hospitals to be honest. But those medications should not be taken in those patients, because they increase the risk, make the threshold of having epileptic seizures really goes down. So pethidine should not be used, and diamorphine or things like that should be used alternatively. For the anesthesia team, I would say, and they probably know about that, but if you working in settings when you feel like your team is not super familiar with those patients, it's always good to just double check that there is no ketamine and sevoflurane for those patients, because both of them actually increase the risk of having seizures. And the other thing, and this definitely should be arranged with the neurologist. So if the patient is known to have epileptic seizures, like she's a high risk, she's getting epileptic seizures all the time, and not all the time, but she has had epileptic seizures during pregnancy, and you know that she likely will have seizures at the time of labor, then it's important to consider a long-acting benzodiazepine. Clobazam is one of the medication, and you can, it's not necessarily that you actually be proactive and ask for that, but you can speak to the neurologist. So you are ready, if she goes into labor, that you can give her this medication as a way of prevention of going into epileptic seizures. So that's one of the options, and I would say just talk to your neurologist if you have concern, what's the best way to give this medication and if we need to give it. So this is to prevent seizures, but if she goes into seizures, what should you do? And this is very important because remember, typically I don't really ask doctors to really recall every single dose and every single regimen for treatment. There is millions of regimens and you don't have to really recall everything, because in many situations, if you see a patient, you can always check, open your book and just be sure what's the dose, as it's always good to verify. But in emergent situations like this, you don't have the time to calculate a dose. That's one thing. And the other thing is you should be sure that the medication is available. So if you have a patient with epilepsy that's in labor, you should be sure that in the fridge, the medication is available and you can give it right away if she goes into seizures. You shouldn't be just expecting that to happen and then decide. And that's why I mentioned these things. So they should be, any patient with epilepsy, you should have this available anytime. So if she goes into epileptic seizures, she should be placed in a left lateral position, of course, to prevent obstruction of the airways and reassure that there's airway and oxygenation. And then you should give her the medications that stops seizures. Lorazepam is the ideal medication, and it's given as an IV. So it's important to have this medication available, calculate the dose, and make the dose ready if you need it. So it's 0.1 milligram per kilogram. That's, I mean, roughly, if you didn't have the time to make calculations, just give 4 milligrams. That's it. And then you can repeat that around 15 minutes if needed. So 4 milligrams, repeat it after 15 minutes if needed. This is a lorazepam, or ideally just calculated based on the weight of the patient. If for any reason you don't have lorazepam available, you can use a diazepam for sure. And the diazepam is actually a higher dose. So just remember, lorazepam was 4 milligrams. So diazepam is a little bit higher. It's 5 to 10 milligrams if you give it as an IV, and it's slow IV. Or even if you can give it as an IV and you're going to give it as a rectal suppository, then it's going to be higher, so 10 to 20. So we start with 4 milligrams, 5 to 10, and 10 to 20 milligrams. And remember, you're giving the diazepam, and you still can repeat the diazepam in 15 minutes. But we always mention that you can use a rectal diazepam because in certain situations, the patient presents to you with seizures. This is the first presentation and there is no IV access. So if there's no lorazepam, you can use a diazepam, but the lorazepam is the ideal one. And if you don't have an IV access, you can use a rectal diazepam for this purpose, and you can repeat it in 15 minutes. Phenytoin and fosphenytoin are basically the medications that are used if the other lines just failed. So it's like a second line for resistant cases. And this is given actually as an IV infusion. And the dose is actually much higher. So it's 10 to 15 milligram per kilogram. So I would say lorazepam, diazepam are the medications that we typically use. Phenytoin is like a second line if things are not getting under control with the other medications. There's a side note, and just remember the side note, it's very important. Sometimes if you know that this patient is under induction, augmentation, or even spontaneously in labor but is advancing in labor, just be sure that it's not an uterine hyperstimulation, because sometimes you see on the monitors that she's contracting like 5-6 contractions in 10 minutes. And then this is likely how these seizures were triggered. And in this situation, you should always consider a tocolytic, especially if things are persistent and they are not responding. So a tocolytic can help just easing the contractions and help things get under control. So it's important to highlight this. So if the patients are actually having recurrent seizures, and this is like the indications when you have to deliver the patient and change the plan. So if the patient is really having like recurrent, and I think that's very intuitive. So if the patient is having like recurrent seizures, in delivery and she's not even close to delivery, then you may have to go for a C-section, just because she is not. And just thinking about it, the patient is seizing, and even if she goes to the second stage and you're trying to do an instrumental delivery and she seizes, that's going to be really bad. So you have to be really conscious of the circumstances, and if she's really having recurrent seizures with labor, just go ahead and just deliver as fast as possible. The other thing is, as we mentioned, we keep the baby under monitor. Just remember, there is hypoxia absolutely with seizures, and the baby will be affected by the hypoxia, and you will see the baby having decels or bradycardia, but this should recover once the seizures are done, or are recovered as well. But that's why we keep the baby on the monitor, to be sure that the baby recovers fine from the seizures, because if the recovery didn't happen in 5 minutes, then you have to move for a C-section. Because basically there's something in there, because as we mentioned, it could happen easily that the patient has placental abruption with the seizures, and then the baby will not recover. The situation will actually get worse. And that's why you should be sure that the baby recovers within 5 minutes, because if this didn't happen, just go straight forward and do a C-section. And as mentioned, pediatric team should be here to support the baby. And if the baby or the patient has been having recent medications, like as we mentioned, we mentioned in the treatment of seizures that we're giving benzodiazepines, for example. So if you have given benzodiazepine, either for control of seizures, or you have been doing anti-epileptic drugs as a part of the medication at the time of labor, because we said we're not going to stop that, you should tell the pediatric team about it. This is very, very critical, because they need to know about it. There could be some withdrawal symptoms, because these medications goes to the blood of the baby. And once the baby is delivered, there will be like abrupt drop of these livers in the baby's blood. And then withdrawal symptoms can happen and affect breathing, neurological, like CNS function. And they should be aware of that, should be ready for that, and have the medications for that. Okay, so last stage is after the baby is delivered, postpartum care. And I would say, first in your checklist is to prevent seizures again. Second in your checklist is to prevent toxicity. I will mention, let's go point by point. So first thing is preventing seizures, and she's still at high risk of having seizures in the first 24 hours, up to 3 days after delivery, actually, especially if this lady is known to have seizures immediately before delivery, before pregnancy. So if she had seizures within 1 month of conception, she has a high risk of having seizures within 3 days of delivery of this baby. What can you do is definitely to, again, continue the medications, continue anti-epileptic medications. Don't stop anti-epileptic medications after she delivers a baby. And the other thing is similar to what you did in labor. Just be sure that there's good hydration, reduce stress, give good pain control and pain medications. Try to just optimize the factors and just minimize the triggers for seizures. The second thing is prevention of toxicity. And simply, we say toxicity because this is particularly in patients who had increased dose of their medications during pregnancy to get things under control. Because once she delivers her baby, there is a chance this dose is now higher than what she needs. And this can bring her into toxicity. So it's very important to communicate with the nurses, with the midwives, communicate with the team that they should watch for like neurological symptoms, basically drowsiness, diplopia, like change in vision, or unsteadiness. So these things, if they notice any change in behavior, or if the patient herself like is not feeling okay or having visual symptoms, she should report that to them, and they should report that to you, because you will need a very quick neurological review to rule out toxicity. That's important. Another thing to prevent toxicity is you need a neurological review within 10 days of delivery of the baby. So need a neurologist to come in and discuss the dose and see if we need to like decrease the dose or get the dose back to the normal, or like change in medication, or like whatever. to just give her the right medication for this stage of her life. So that's very important within 10 days. If she has to actually go down from a higher dose to a lower dose, that should be done, slowly, as agreed with a neurologist, to just be sure that there's no sudden drop bringing her into seizures as well. So this is very important, and this is definitely your responsibility. Last few things I would say in your checklist, just breastfeeding. Just encourage her to breastfeed, it's fine. It's always nice to actually just tell her that she should watch for any abnormal symptoms of the baby. The baby is not feeding well, doesn't look okay, it's not reactive as it used to be, because these could be signs of withdrawal if she has been taking these medications for long in pregnancy. So important to tell her breastfeeding is fine, watch for your baby. The other thing is, as we mentioned, always just with patients with epilepsy, just always check on her mood, be sure that she doesn't have any signs concerning of depression. The last thing is contraception. Please, contraception. I know, we don't do that a lot, but in certain patients, especially those who have medical disorders, chronic medical disorders, it's a good chance to speak to them before they go home, because you're probably not going to catch them later. Sometimes they don't really attend the postpartum visits, or they see people who cannot really counsel them accurately on contraception in their situation, or not comfortable actually counseling them on their situation. And the reason here is you want to be sure that she gets right advice. You know that they may not want to get pregnant, or they want to really space things, or they want to get pregnant, but they want to optimize things before they get pregnant. So you really don't want them to go into an accidental, unwanted pregnancy. And this is your rule, because you have the information, you have the background, you can really counsel them very well on what contraception they can use, and hopefully you can just establish the contraception they want right away before they go home. And I always say, this is a nice table. It's basically the biggest challenge about contraception with epilepsy is, certain medications really have interactions with contraception. And the key here is actually if these medications are enzyme-inducing or not enzyme-inducing, because some medications, some epileptic medications are enzyme-inducing, increasing the metabolism in the liver, which probably will result in a higher rate of breakdown of, or a higher rate of breaking of destruction of hormonal contraception, which will result in contraceptions being at high risk of failure. So it's important to review their medication and see if they are on enzyme-inducing or not, because if they are not on enzyme-inducing medication, they can use whatever they want as a contraception. So how could I know? This is a list, and I definitely say it's not an emergency. So just review the medications, be sure that they are not enzyme-inducing. You don't have to really recall all the medications. But for examination purposes, or for your quick purpose, I would say enzyme-inducing start with top COP. So COP, C-O-P. So any anti-epileptic medication starting with B was P, starting with O, starting with C is an enzyme-inducing likely. Or if it's top, and top here means topiramate. So topiramate is the other one. So C-O-P or topiramate, not the T, but the topiramate specifically is the one that's enzyme-inducing. So if it's any of these groups, they cannot take the oral contraception. They can only use a copper ID, and they can use the Mirena, or the hormonal ID, and they can use the injectables. So the Depo-Provera or the medroxyprogesterone acetate injectables, which are taken every 3 months. These are the options for them, actually. But if they take the oral contraception, the likelihood of failure increases by 3 times. So it's 3% that she can get pregnant, which is not good. The other thing is, if she's using non-enzyme inducing epileptic medication, she should be fine. She can use whatever she wants on a contraception. But there is one extra information you should always remember. Remember that nice, friendly medications that we like in obstetrics, which is the lamotrigine. It's nice, we like it, but it's always important to know that it should not be taken with estrogen-containing contraception. And the reason here is different, is actually the reverse. Is estrogen-containing contraceptions can decrease the level of lamotrigine, and then if the patient is taking lamotrigine, drop in the levels can cause her to go into seizures while she's on treatment. So lamotrigine doesn't like estrogen-containing contraceptions. Other medications, fine, she can use wherever she wants, but lamotrigine with estrogen, no, don't do that. So that's the end of it. I hope that lecture was really informative and really touches every single thing that we need to know about managing patients with epilepsy. Sorry if it was a little bit long, but we're trying to cover a lot of things here, starting from the beginning of pregnancy to the end of pregnancy. Thanks so much for watching, and seeing you in the next lecture.